type A aortic dissection occurs approximately 2,000 patients per year in USA, about 400 to 500 times per year in Germany. Mortality rate 1 to 2% per hour, as we all know, for the first 48 hours, and then it drops thereafter. And 15 to 25% of early mortality in surgical series, and we know that the mortality rate is also higher if organ malperfusion is present at the time of surgery. And despite advances in our treatment of this disease process, there will be patients that will even develop complications after successful surgical management, and that's about 15 to 30% of patients that will eventually develop aortic dilatation or rupture, which is the most common cause of death, progressive aortic valve regurgitation, or organ malperfusion that needs to be treated with some other type of intervention after the surgical repair of the type A dissection. The entry tear, as we all know, most frequently occurs in the ascending aorta on the convex portion just above the sinotubular junction. About 10% of patients have a tear in the aortic arch, and 20% in the proximal descending aorta. And the distribution of tears is very important for use of the Osiris device, and this is something that Jörg will be talking about in detail. The goals of type A aortic dissection surgery are, number one, to get rid of the intimal tear, so the primary tear, which is not always possible in all patients, but if it's in the ascending aorta, this should certainly be done in 100% of patients. We want to decrease or obliterate blood flow into the false lumen of the dissected aorta. We want to always replace the ascending aorta in all patients in order to prevent future pericardial tamponade or coronary or aortic valve complications if the dissection spreads more proximally. And aortic arch surgery is done most of the time in most centers. In our center, our standard operation before using the Osiris device was at least a hemi-arch procedure. We want to make sure that the aortic valve is competent at the end of the operation using whatever method that may be necessary to achieve that. And we also want to try to correct malperfusion. And this is something that we sort of just kind of hope happens at the end of the operation. But with the Osiris device, we now have an active way of intervening in order to correct malperfusion.